So the next presentation is on office Pipelle Biopsies in Endometrial Disease Diagnosis. This is a retrospective review in relation to Final Hysterectomy Histological Result from my practice. So I did all the Pipelles myself over a couple of 2 to 3 years. So Pipelle biopsy is a minimally invasive outpatient procedure for endometrial sampling. It was introduced by Cornier in 1984 using a suction mechanism. It has a high sensitivity, sometimes up to 97% in detecting carcinoma and hyperplasia. It's cost-effective, very simple, and requires no anesthesia, no theater, and commonly compared with hysteroscopy and DNC for diagnostic reliability. So this is the Pipelle company actually that I normally use. So study objectives were to assess adequacy of Pipelle biopsy samples, compare the Pipelle histology with final hysterectomy, the histology, and evaluate diagnostic reliability in local ObsGyn practice, that is my practice, and analyze outcomes in endometrial hyperplasia and malignancy. So methodology, it was a retrospective review of my cases. These are cases managed by myself in both my Meru private practice and my Isiolo public practice. And I compared the Pipelle results versus the final hysterectomy histology results. I included postmenopausal bleed in women, AUB, hyperplasia, polyps, and malignancy cases. So the key results were that I had more than 98% agreement with final histology after hysterectomy. Hyperplasia cases largely confirmed. I had one invasive carcinoma successfully detected and linked up to care. And polyps were occasionally underdiagnosed in my patients. So the cases that I saw in my review were endometrial hyperplasia, benign endometriums, polyps, and endometrial malignancy. So literature comparison between Pipelle, the diagnostic accuracy of Pipelle biopsy. There was a study in 2025 that had a 97.6 agreement compared with DNC in cases of endometritis in infertility. Then another study that was done in 2025 saw a 99% sample adequacy done well, because that's an issue that's one of the issues in Pipelle histologies, the adequacy of samples. And a study in 2021 showed 82% sensitivity for malignancy. And another meta-analysis actually showed that Pipelle is actually very good in endometrial carcinoma detection. Advantages of Pipelle is that it's affordable, minimally invasive, no anesthesia required, high sensitivity and specificity, well performed, useful in low resource settings. Limitations is that it has a limited detection rate for focal lesions or polyps. Inadequate samples may require repeat biopsies or hysteroscopy, which is the gold standard actually for endometrial lesions. And clinical judgment remains essential. As much as you have done the Pipelle, you need to still correlate clinically with what you suspected for your patient. So conclusion is that Pipelle biopsy is a reliable, accurate, and affordable office procedure for diagnosing endometrial disease. Strong correlation with hysterectomy histology in my patients. Highly effective for hyperplasia and carcinoma diagnosis. And hysteroscopy and DNC is still important in selected patients. It's a valuable tool in resource-limited gynecological practice. So my logistics, I have done actually over 30. So what I presented was actually what I could get in my emails. Pipelle versus hysterectomy. I've had other patients where maybe they come with a printed report and I didn't really keep track of it. So I've done so many over the last 3 years. I normally source from one importer. Purchase price depends on the dollar, around $3,000, sometimes $4,000 per piece. So I normally do them in clinic I normally use an IUCD insertion set, just because I just need a tenaculum and a ring forceps, that's it. And of course a sterile drip. I do them in the office, not in theater, not in a side room. No anesthesia, no cervical ripening, mostly no analgesia required. Sample immediately preserved in clinic and couriered for histopathology. So the total cost for cash payers, including histology, comes to around 8,000 shillings. When you count consultation fee, the cost of Pipelle procedure, and sending the cases for histology. I had this very unique rare case that I did in 2022, but I did it via DNC. Could this case have been picked via Pipelle? I'm not sure. Because it was a 67-year-old woman with postmenopausal bleeding on and off. She had a pap smear that showed Haig seal. An ultrasound showed a suspicious endometrial lesion It was actually 2.3 by 2.1 millimeters. It was very small, 0.2, not centimeter, millimeters, very small, with increased vascularity of the endometrial lesion, very tiny, less than half a centimeter. So I did DNC for this case, and I think I referred this case to Dr. Rachel and all when you were at KNH. It was a very, very, very unique case of actually an invasive high-grade squamous cell carcinoma of the uterus. How many times have we caught? It's a very rare, very, very rare to have squamous cell carcinoma in the uterus. So I asked myself this question in retrospect. Had I done a Pipelle, would I have picked this case? It was a very tiny, tiny lesion, very tiny, only that the radiographer had insisted that it was very vascular. And that's why I did a DNC for this case. So this patient went to KNH. She had surgery done, and 3 years later, she's doing very well and disease-free. So thank you. So these are the patients that I presented. So these are actually the details of the patient. Number 1 had AUB with thickened endometrium. The Pipelle biopsy said benign cystic glandular hyperplasia, Swiss cheese type. She chose conservative treatment, but then she continued bleeding. We did TAH. It confirmed the diagnosis accurately, no malignancy. Second case had a thickened endometrium, 1.6 centimeters. It said benign endometrial tissue. Advised on TAH. This patient, we lost her to follow-up because she refused surgery. But the Pipelle biopsy said benign endometrial tissue. The third case was a non-CA colon patient. So we did Pipelle, showed an invasive high-grade serous carcinoma. We referred her for gynae-oncology care. The fourth case was a patient who was post-chemotherapy for metastatic choriocarcinoma, but a PET scan at KUTRH had shown vascular lesions along the endometrium. We did Pipelle. It was benign tissue, no residual tumor. She's doing very well, planning to conceive this year. Fifth case, heavy prolonged menstrual bleeding. She said benign secretory phase endometrium. We put for her an Avibella, I think, yeah. She's doing very well with treatment, and the endometrium has really gone down. Then the sixth case was unexplained postmenopausal bleeding after 4 years of amenorrhea. Said benign endometrial tissue. She refused surgery despite, persisting on, insisting that we do the surgery for her. She had a repeat DNC in another facility because of recurrence of bleeding, still said benign endometrial tissue, lost her to follow-up. Number 7, we had postmenopausal bleeding with thickened endometrium, said hyperplasia with chronic endometritis. TAH confirmed simple hyperplasia. Number 8 was 48-year-old, heavy menstrual bleeding. The Pipelle biopsy said benign and proliferative endometrium. Final outcome was still benign endometrium, but with Hague seal from the cervix. Number 9 was postmenopausal bleeding, said scant benign endometrial tissue. I did her surgery, actually this one, the number 9, and I just got the results. It's actually benign endometrium again. Number 10 was endometrium that was 8 millimeters in a postmenopausal woman, hyperplasia with severe atypia, but the final outcome was hyperplasia without atypia. The hysterectomy said without atypia, the Pipelle had said with atypia. Number 11, simple endometrial hyperplasia fully confirmed, accurate on hysterectomy. Number 12, hyperplasia with atypia. Again, this one there was also, it was hyperplasia with atypia, but the final hysterectomy said without atypia. Either way, she got help. Number 13, benign endometrium with query polyps. Benign polyps were confirmed. That's why I was telling you that Pipelles are not very good with polyps detection. 14 was again benign endocervical polyp, multiple polyps on hysterectomy. And number 15 said scant benign tissue. We did a TAH in April 2026, showed benign endometrium with atrophic endometritis, benign endometrial polyps. So bottom line is to say that we did not miss any serious case for all the 15 patients that I analyzed in detail. That's the end of my discussion.